So for the next few minutes, I'll be speaking about stopping or interrupting dual antiplatelet therapy and the risk with DES thrombosis. I have no disclosures for this talk. So in terms of a very quick and brief outline, I'll start off by just going over some issues pertaining to stent thrombosis, the incidence, the impact, risk factors, just to remind ourselves what we're dealing with. Then the three key messages I want to sort of impart are what are the key elements that influence a risk for stent thrombosis after you stop dual antiplatelet therapy. And there's really three. One is this sort of element of time after PCI. Two is the mode of cessation. In other words, why did you stop dual antiplatelet therapy? And third is the stent platform. And then finally, some closing comments on sort of the evolving paradigm for dual antiplatelet therapy after PCI. So about 30 years ago, we learned about this entity called stent thrombosis, and we quickly also learned that to mitigate this risk, we had to give patients antithrombotics. And in the late 1990s and early 2000s, we found that the best combination was to give two antiplatelet drugs, one of course being aspirin, the other being an inhibitor of the platelet P2Y12 receptor. And of course, that's the sort of paradigm we currently adhere to and is supported by guidelines today. And when we think about stent thrombosis, we begin to organize our thoughts in terms of time after PCI. So we have sort of the early stent thrombosis events that are sort of acute or subacute in the first 30 days. Then, of course, there are the later events, 30 days or 1 year thereafter. And this is kind of a convenient hierarchical grouping that allows us to also organize our thoughts with respect to stopping antiplatelet therapy in these exact same identical time intervals. And as with most invasive procedures, cardiac procedures, we know that the majority of the patients who will end up sustaining stent thrombosis, it will occur early in sort of the acute subacute phase. About 75% of the patients who have events occur at that time interval. Importantly, however, there is still a residual risk for stent thrombosis even in the later time period, so we don't want to forget that. And why do we care so much about stent thrombosis? Certainly, we've had a lot of talks and there's been much discussion about the fact that this entity is decreasing. It's occurring less frequently. Nevertheless, when stent thrombosis occurs, it's not just morbid, it's still a mortal complication of PCI and something that we're all very, very concerned of. You can see in these data, when patients experience, again, those early events in that first 30 days or so, case fatality out to 2 years, about 20%, so 1 out of 5 of these patients die. That risk is halved if it occurs later, but still is substantial. So still 10% of these patients may die over a 2-year period. So still a very important complication that we cannot ignore. And when we sort of think about all the different ingredients that contribute to risk for stent thrombosis, we really realize that this is sort of a multi-dimensional construct. On the one hand, you have patient-related factors here at the top. In other words, how does a patient present? What morbidity do they have? Do they have diabetes? Do they have renal impairment? So on and so forth. There are procedure-related parameters. Are we dealing with the bifurcation? Are we dealing with the long lesion? How many millimeters of stent are we implanting? Then on the bottom left, we have device-related parameters. What are the thickness of the stent struts? Are we dealing with durable or biodegradable polymers and so on? And then finally, of course, the issue of antiplatelet therapy. So how do we sort of organize our thoughts around all of these different elements? What matters most? What matters least? And where does antiplatelet therapy discontinuation play in this? Well, Yakovu and colleagues published this paper in 2005, and these results have really borne sort of the test of time. And as you can see, certainly the strongest risk factor, at least in terms of hazard ratios as expressed in this study, is premature antiplatelet therapy discontinuation. Other parameters certainly matter, but certainly that factor right there, stopping antiplatelet therapy, seems to be the most concerning, both for subacute, late, and sort of overall stent thrombosis rates. And this has been borne out in multiple other studies. These are data from the Premier Registry. Now, this is acute MI patients, and you can see the risk for stent thrombosis is almost 10-fold higher in those patients who stopped their P2Y12 inhibitor in the first 30 days compared to their counterparts that were still taking it. So certainly, most of these events are occurring in the first 30 days. Certainly, if we stop antiplatelet therapy in that time interval, we are in a lot of trouble with respect to stent thrombosis risk. But I think the key question and sort of the first key element that I want to bring home is there sort of an inflection point? Is there some time after PCI where we begin to see an attenuation of this risk? And this was shown very elegantly in this paper by Aroldi and colleagues in 2007. And what they did here is they plotted the risks for thrombosis in patients who had stopped thienopyridine in the red and compared those who continued here in the blue. And again, you see the same message that we've seen before. In the first 30 days, risk is highest, about 5-fold higher, not surprising. You see immediately thereafter, in this up to 180 days, you still see risk about 3-fold higher, but certainly less. But look what happens after 6 months. After 6 months, you actually see no difference in risk between the patients who are still taking versus those who are not taking their antiplatelet therapy. It's indicating perhaps an inflection point right at 6 months. And this important and sort of provocative insight suggests that there's a temporal gradient in stent thrombosis risk after you stop your dual antiplatelet therapy, and that gradient's a function of time after PCI. Highest in the first 30 days, less so up to 6 months, and then it really seems to completely disappear after that. So certainly time after PCI is important, but what about mode? Does it matter why you go off antiplatelet therapy? Now, a lot of our data come from clinical trials, and in clinical trials, you have to be on therapy, and if you go off, it's usually because of some a reason that has to do with endpoints in the clinical trial. But what about in a real world context, what we deal with in our patients every single day? And this insight was provided to us by Dr. Moran and colleagues from the Paris Registry when, for the first time, every single occurrence of antiplatelet therapy cessation was pre-specified and categorized according to the underlying mode. So you had some patients in whom antiplatelet therapy was discontinued because their doctors made a decision to stop antiplatelet therapy because they felt it was safe to do so. You can see there was absolutely no increased risk for stent thrombosis in these patients. You have patients who interrupted antiplatelet therapy. These are patients who needed endoscopies or minor surgeries. They went off antiplatelet therapy for about 2 weeks and went back on. Again, no increased risk for thrombosis. The risk was completely and entirely confined to those patients who disrupted, meaning they were non-adherent in the majority of cases or had an antecedent bleed. So again, the sort of second element that influences risk after stopping antiplatelet therapy, not just time after PCI, but also the mode. The reason that you stop antiplatelet therapy is completely and entirely linked to the risk of stopping antiplatelet therapy. And finally, what about stent platform? A lot of the studies I've just spoken about had a fair number of patients, if not all, that were treated with first-generation drug-eluting stents here on the left-hand panel, and the newer second-generation stents, which are now used universally across the world, certainly have a very different healing profile as shown in these histologic sections. These are taken several months after implantation. You can see the metal struts are nicely healed, covered by endothelial cells, whereas these first-generation stent struts are still exposed to free-flowing blood. And why is that important? Well, that's important because we learned from the ESC firestorm about 10 years ago that when these stents were implanted in sort of off-label indications in patients, thrombotic risk actually exceeded that from what was observed even in bare metal stent patients. And so if we're dealing with stents now that appear to be safer, what do the clinical studies show? And they actually do show that when we look at the newer generation stents, the standard bearer being the cobalt chromium everolimus eluting stent, when we compare that to other stents, we can see, and this has been shown in numerous meta-analyses, perhaps the most famous is this one from 2012, the stent thrombosis risk is much, much lower with these newer stents. And the implications of this are really twofold. If these stents are really safer and they're less thrombotic, it probably means that the penalty one pays if you stop antiplatelet therapy is less. It also probably means that the benefits you get from keeping patients on antiplatelet therapy is also less. So let's see if that actually is borne out by the data. This is results from meta-analysis done from our group, published last year, looking at sort of that first point. In the top panel, you see risk ratios for short antiplatelet therapy and stent thrombosis risk with new stents. At the bottom are the first generation stents, and there was evidence of interaction here indicating that the penalty one pays for going for short dual antiplatelet therapy durations is accentuated with the earlier stents. And if we look at sort of the corollary, the other side, what's the benefit we get from going for long durations? We see exactly what one would expect. These are data from the DAPT trial. What I've simply plotted here are the MI rates in the patients who got 12 months versus longer duration and the number needed to treat according to whether or not they got a sirolimus, paclitaxel, or everolimus eluting stent. You can see the number needed to treat. In other words, the number of patients you would have to expose to dual antiplatelet therapy to reduce one MI is 2 to 3-fold higher with the everolimus eluting stents compared to the earlier generation stents, which means you have to expose that many more patients to risk for bleeding. And as we heard in earlier lectures, bleeding is not something that is to be dealt with lightly either. And so we have now introduced other terminology in this lexicon, which has to do with what is the mandatory duration. In other words, what's the shortest duration of dual antiplatelet therapy that we need to expose our patients to ensure that they are not going to experience any early thrombotic events. And the guidelines have kind of come to an agreement on this in line with our European colleagues, and have said that really the duration is probably 6 months. That's how long we really need to give patients, particularly with newer generation stents in the absence of ACS, in order to make sure they don't suffer any early thrombotic events. And what do you do after that 6 months? Well, the paradigm is now really evolving to doing patient-based, risk-based assessments, and there's going to be a whole host of scores. 2 have just been published in the last about 6 months, and I'm sure many more will be forthcoming. When you get out of that mandatory DAPT duration time, 3 to 6 months, you want to assess patient risk and make decisions to either continue or stop DAPT thereafter. And so, in conclusion, I can say certainly the risk for stent thrombosis are related to a host of patient, device, and procedural parameters. Stent thrombosis remains an important, albeit uncommon, complication of PCI. And most importantly, the relationship between stopping antiplatelet therapy and stent thrombosis risk is related to the time from PCI. It's related to the reason or mode we stop, and it's very much linked to the kind of stent we're implanting in our patients. And the mandatory duration now seems to be about 3 to 6 months after new generation stents when we are dealing with stable CAD patients. Thank you.